Welcome to the Boston Structural Heart course and another presentation on the Cardiac Anesthesia Fellowship Lecture Series. This time we'll be discussing the general principles of assessment of regurgitant cardiac valves, and then in the second part we will apply these principles specifically for assessment of mitral regurgitation. As you might have noticed, this is the second time I'm uploading this presentation because the first one wasn't perfect and the audio and the video were out of sync in the middle and the later part of the presentation. It wasn't perfect, so we deleted it, and after having recorded it 3 or 4 times in the last 2 days, I finally figured out what the problem was, and now this is uploaded again with completely synchronized audio and video. At the same time, I also want to thank you, all those people who have subscribed to this free educational resource for trainees not just in the United States but all over the world. If you're viewing this video, please subscribe because this will mean a lot of encouragement to us, and again, it's completely free and educational for all trainees interested in furthering their knowledge of intraoperative echocardiography. Enjoy and good luck. Welcome to the Boston Structural Heart course. Today, in the continuation of the Cardiac Anesthesia Fellowship Lecture Series, we'll be going over the intraoperative echocardiographic assessment of mitral regurgitation. But in the first part of the presentation, rather than specifically discussing mitral regurgitation, we'll be discussing the general principles of assessment of regurgitation of any intracardiac valves. And in the second part of the presentation, we'll take these principles and apply them directly and more specifically for the echocardiographic assessment of mitral regurgitation. The first question to ask is why this is so important. Now, mitral regurgitation is one of the most prevalent valvular disorders. Discordance between preoperative and intraoperative findings is very common. We've all been there when it's under or over-reported. And general anesthesia has profound impact on the severity of hemodynamics, severity of mitral regurgitation through variations of hemodynamics. And the most important part is that we have limited time to make a very critical clinical decision that could have a significant change in the direction of intraoperative surgical decision-making. We'll start that with these dilemmas in 2 short cases. The first one being a 60-year-old female without any significant family or past history, presented for 3-vessel coronary disease and CABG. She had an uneventful induction and stayed pretty hemodynamically stable. As you can see, after induction, the severity of mitral regurgitation is only about trace, but 30 minutes later, she starts to become a little hypertensive and tachycardic, and the severity of MR gets worse. And another 5 more minutes by any standards, this is severe mitral regurgitation. You can see the continuous wave Doppler in the early part demonstrating an early systolic and later part a holosystolic regurgitation jet, implying that it was significant change in the severity. We immediately instituted anti-ischemic therapy, that is nitroglycerin, some heparin, some beta blocker, 100% oxygen, informed the team, and she responded pretty favorably, and 10 minutes later, the severity of mitral regurgitation was reduced to pretty much baseline. Based on a favorable response to anti-ischemic therapy, we assumed that revascularization is going to work for her, and that's exactly what happened. And after bypass, her mitral regurgitation was back to baseline, and she did pretty well post-operatively and did not have any more severe mitral regurgitation. Now, let's look at the second patient. It's a 65-year-old patient for elective CABG surgery with a little different past medical history, having an early January outside hospital transthoracic echo which demonstrated normal mitral valve leaflets with mild mitral regurgitation. Then a stress transthoracic echo, I don't know why they did it, demonstrated severe eccentric mitral regurgitation on stress echo. And lastly, on 6/30, that is June 30th, she had a BI resting transesophageal echo which demonstrated mildly thickened mitral valve leaflets with mild mitral regurgitation. So there was some contradictory information. On the day of surgery, after induction, it seemed pretty straightforward. She had normal ventricular function and trace mitral regurgitation. We took a good look at it. There was still trace mitral regurgitation, and a clinical decision was made to induce a phenylephrine stress challenge and to start a phenylephrine infusion at about 0.5 mics per kilogram per minute to match her preoperative hemodynamics and then see what happens. And as you can see, as the blood pressure was raised to about 130 over 60 millimeters of mercury, the severity of mitral regurgitation changed from trace to about moderate. But if you look at it closely, there's not only a change in severity grade, but also a change in the direction of mitral regurgitation jet, which implies that this could be a different mechanism right now, possibly a posterior leaflet retraction. We interrogated the jet using simultaneous orthogonal plane imaging to look at it in multiple different directions, but we were pretty certain that it is not a holosystolic jet, but it has certainly changed its severity grade as well as its characteristics of directionality also. We used three-dimensional imaging to look at the Vena Contracta because it was not a holosystolic jet, and we wanted to see where exactly the regurgitation and when and where was the most profound regurgitation jet. And as you can see in the lower right corner here, that it was more so on the A3P3 side rather than the middle of the valve, and it was a pretty significant mitral regurgitation jet. As a result of this finding of a change in severity and character, the patient underwent a mitral valve annuloplasty, and you can see post-bypass, she had a pretty decent result with significant apposition of the leaflets and trace mitral regurgitation, and the patient did well post-operatively as well. Now, these are two cases of intraoperative mitral regurgitation. They both had different clinical approach to management, a different way they presented in the operating room, a different kind of discordance, and they both led to different clinical outcomes as well. Now, the outline of the talk is that we are going to be going over general principles of regurgitation, and then specifically we'll address and apply these principles to the severity evaluation of mitral regurgitation in the operating room. And for the purpose of this presentation, particularly for the general principles, I have verbatim followed the recommendations of the non-invasive evaluation of native valvular regurgitation by the American Society of Echocardiography. And we have gone over each of these topics in detail and putting slides and actual echo clips to each of these principles to make it easier for people to understand. So in all fairness, you'll find this presentation as a graphic outline of the American Society of Echocardiography guidelines. So enjoy. So the first is introduction of these general principles of assessment of regurgitation. And as you can see that we have to have comprehensive information regarding this patient, which involves clinical information of symptoms, clinical findings, demographics, imaging of the valves that involve significant and very detailed assessment of the motion, the prolapse, flail, restriction, tenting, and then Doppler echocardiography of the valve that involves color flow Doppler, pulse wave Doppler, continuous wave Doppler, then use these Doppler and two-dimensional information into making quantitative parameters of regurgitation to give a very precise information regarding the severity assessment. And lastly is the use of three-dimensional imaging. However, in this entire process of intraoperative assessment, the challenge is to assess severity, identify mechanism, diagnose etiology, quantify remodeling, and assess suitability for repair or unsuitability and selection of patient for mitral valve replacement. Now, the real challenge is to be able to perform that sometimes in 10 minutes or less. So therefore, you have to have a very methodical and a very algorithmic approach to the severity assessment so that every time you can get to the same reliable information which actually makes a difference in patient's outcome. The next is evaluation of the valvular regurgitation and identifying the mechanism of regurgitation. Now that's the core of assessment of mitral regurgitation. And really as an intraoperative echocardiographer, it's not just enough to describe the presence of regurgitation. It is important to describe the mechanism and identify the etiology that led to that mechanism, which could be excessive motion, restricted motion, or normal motion. So therefore, just assessing the severity alone is half the information. There's a lot more to it than simply saying it's mild, moderate, or severe. So therefore, we have to define the etiology and mechanism also. And the evaluation of this echocardiographic assessment is based on some general principles that involve comprehensive imaging, integrative interpretation, individualization, and precise language. And we'll go over each one of them, what it is. And you can see they're all kind of tied to each other in a kind of a Venn diagram to give you a global and a holistic information about what the mitral regurgitation severity is like. Comprehensive imaging means it's just not color flow Doppler. You have to employ all modalities available to that echocardiographer at that time, which involve color flow Doppler, M-mode, pulse wave Doppler, continuous wave Doppler, and all using them to provide both qualitative as well as quantitative information, which should corroborate each other and guide the surgical decision making in the operating room. It has to be integrative information, which means you have to account for the presence of anatomical and physiological abnormalities and operative variability in evaluation, which means which specific leaflet, which direction. So what you see as a structural abnormality has to fit in the context of what we found with a color flow Doppler, pulse wave, and continuous wave Doppler also. So each and every piece of information has to be integrated into it. Then is individualization, that the regurgitation measures and signs require individualized interpretation. The patient's height, weight, body surface area, the size of the cardiac chambers, the lengths of the leaflets, so they have to be individualized and specific to each patient rather than a cookie cutter approach of assessment and making decisions on everyone. And lastly is precise communication. The terminology, the severity assessment grades should be very clearly and unambiguously communicated to the team taking care of the patient, because both the severity, mechanism, etiology, location, and associated lesion and cardiac response have to be communicated for them to make an educated decision which is in the best interest of the patient at that time. So precise communication and agreement on what we define as 1+ and 2+ and mild or moderate or mild to moderate or severe has to be precisely and explicitly known to each team member what is implied by this information. And lastly, for echocardiographic imaging goals, we have to be very specific, like I said in the beginning, to define the mechanism, etiology, severity, and impact, that is the remodeling of the intracardiac chambers. Then comes the core of valve evaluation, and that's echocardiographic imaging, which involves looking at the valve structure and severity of regurgitation and the impact of regurgitation on cardiac remodeling. So for echocardiographic imaging, the most important is to look at the structure of the leaflets. All the leaflets have a significant coaptation reserve, which means the degree of apposition of the leaflets with each other is kind of a structural and functional reserve for the leaflets to sustain structural abnormalities and dilations and restrictions. And the more reserve they have, the less likely that they will be regurgitant. But as the valve dilates, it retracts, or there are other problems, this coaptation reserve eventually runs out and the valve becomes regurgitation. So the presence or the lack of significant apposition and coaptation of the leaflets is a great or important predictor of the likelihood of regurgitation in these valves, and therefore that's the first thing you should look at it. How far are the leaflets opposed to each other? What is the degree of coaptation with each other? And then the severity of the associated abnormality, structural abnormality, has to be clearly defined, and the valve has to be seen as part of an apparatus rather than two individual leaflets, which include the leaflets, the chordae tendineae, the papillary muscles underlying myocardium, the mitral annulus, and these are the anatomical components and the physiological milieu in which all these anatomical components interact with each other. We should have a clear definition of what prolapse is when the leaflets go beyond the plane of the annulus. Flail, when the undersurface of the leaflet is exposed to the left atrium or the other cardiac chamber, that implies torn chordae, or leaflet perforations when there are holes in the leaflets. We could also look at the leaflet retractions, either they are single or bilateral or annular dilation, and all these have to be specifically delineated and noted. And with the knowledge that although they have a high positive predictive value of significant and severe regurgitation, the absence of regurgitation does not exclude severe regurgitation. This has to be known. And lastly, the role of three-dimensional echocardiography, which was initially assumed to be of lower spatial and temporal resolution with greater interpolation and lower line density, and therefore was only known to provide some complementary information. But as you can see in this rendition, that as our algorithms for three-dimensional reconstruction improve, the pictures and the graphics are becoming more and more realistic, and the quality is significantly improving. And in this case, you can see we are so specifically able to identify the flail, two scallops of the posterior leaflet being flail in the left atrial en-face view of the mitral valve. So the quality definitely is improving. And it is not just the incorporation of the grayscale image and to have an en-face view of the mitral valve, but it's the ability to manipulate and to be able to look at the mitral valve from both the left atrial as well as the left ventricular perspective, which is anatomically quite impossible in a living patient. And at the same time, incorporation of color flow Doppler information with various color maps can accurately delineate and spatially place the regurgitation jet in the left atrium, which can be very helpful in identifying the severity and mechanism of regurgitation. So then comes the impact of regurgitation on cardiac remodeling. Because the chamber dilation is proportional to severity and chronicity, it is considered a supportive sign, but not a very non-specific sign. The chamber response is essentially the end result of interplay of the jet kinetic energy, reception chamber compliance, and eventually potential energy within the jet. So jet kinetic energy, as you can see, is impacted by the chamber compliance. Kinetic energy is converted into the potential energy in the recipient chamber that leads to elevation of pressure. In this scenario, it is important to remember the caveat that acute severe dilation, acute severe regurgitation may be a brief with potential, a very low regurgitant volume, because the pressure may equilibrate very quickly between the chamber that starts the regurgitation and the recipient chamber. And however, in chronic regurgitation, cavity dilation reflects the severity and chronicity. And in this context, it is important to remember that cavity dilation may be specific for significant regurgitation when ventricular function is preserved, however, it loses its specificity when conditions such as cardiomyopathy and ischemic ventricular dysfunction. So it is important when the ventricular function is normal, but loses its specificity when LV function is depressed. Also, we do not have really normative values for age and gender and body surface areas, and whereas incorporation of body surface area into assessment of chamber size can possibly improve our diagnosis of chronic remodeling, but we really do not have standardized normative values, so that while it's being suggested as a means of equilibrating all these varying hemodynamics and jet severities, but it is not really used routinely. And at the end of the day, echocardiography in general tends to underestimate measurements of LV volumes when compared to other techniques, and when the traced endocardium or the presence of trabeculations can make it very difficult for accurately assess the severity of or the dilation and the accurate chamber size. So the next comes after having viewed the valve with two-dimensional imaging and three-dimensional imaging to know what the structural abnormalities as well as the chamber responses and remodeling are. Next, we apply color flow Doppler, and we tend to look at the jet characteristics. Vena Contracta and flow convergence are the three things that we look at with the color flow Doppler as a first pass. So color flow Doppler is the most widely used method for assessment of regurgitation severity. Say what you say, but this is what is the most commonly used to assess the severity grade of the mitral regurgitation also, or the final grade of regurgitation severity also. What we need to do is accurately spatially place the regurgitation in the recipient chamber, in this case the mitral regurgitation jet in the left atrium, to accurately identify the jet origin, flow convergence, flow contraction, and then eventually the jet expansion, that is spatial orientation of jet in the receiving chamber. Now this is an important thing to remember, that this is a velocity map and not a volume map, which means a higher velocity jet, because of entrainment and causing more turbulence, will be seen as a larger jet, and that is because it's somewhat to do with physics that we so much hated in college, and that's to know the momentum of the jet that it travels through this regurgitant orifice area, which means for a jet originating through a regurgitant orifice with an effective radius of A and a velocity of V, the flow should be A to V. This is what we measured, the cross-sectional area times the flow velocity. And the momentum M is given by QV, or Q being the flow, that would be AV, and then the momentum would be AV square, and by extension, energy is given by QV cube. So the amount of momentum that is within a jet at its orifice remains constant throughout the jet. Thus, a 5 meters per second mitral regurgitation jet with flow rate of 100 ml per second should appear the same by color flow Doppler as a 2.5 meters per second tricuspid regurgitation jet with a flow of 200 ml per second. It's a little complicated physics, but remember, the jet area or the size of the jet is really determined by the momentum of the jet. And also, another very important thing is knowing the Nyquist limit. When does the jet become detectable in the recipient chamber? And a jet begins to be detected when it crosses the minimum detectable velocity set by the system. And in case of intracardiac chambers, typically that velocity when the jet begins to become detectable in the cardiac chamber is within 10% of the full Nyquist limit, which is somewhere around here. When the jet velocity exceeds this portion of the Nyquist limit and comes around here, that you will begin to see the jet and appreciate it visually with color flow Doppler. However, there are multiple other things that impact the jet area. This is an important table to remember. They are higher momentum, which could be because of larger regurgitant orifice area, higher velocity, higher entrainment of flow, low Nyquist limit, higher Doppler gain, and far field beam widening. The reduction of jet area could be because of low momentum, smaller regurgitant orifice area, lower velocity, higher Nyquist limit, and lower Doppler gain. But at the end of the day, the guidelines recommend that the Nyquist limit adjusted for any jet should start at 0.5 to 7 meters per second. Its gain should be enough to eliminate random speckling. And finally, the frequency. Yes, the frequency does, though the transducer does impact the size of the jet, and we'll show that in just about a second. And as you can see, this is the same jet with being seen on the left with the Nyquist limit set at 0.6 meters per second. This one being set at 0.19, and therefore is typical of a dial jet phenomenon, and by simply lowering the Nyquist limit, we have been able to make the size appear bigger and cause more turbulence in the left atrium. This is a jet being seen with a frequency of 2.4 megahertz, and this being seen by a frequency of 5.4 megahertz. And as you can see on the right, it tends to appear a little bigger because higher frequency transducer make the jet look a little bigger. So this is a Nyquist limit of 0.15 meters per second. This is the same jet while at the higher Nyquist limit, but this time we're not looking at the velocity map, but we're looking at a variance map. So it's just a different way of looking at the regurgitation jet. And we talked about the variance maps in the comprehensive exam of the initial lecture series. This is the same jet with now pretty comparable Nyquist limits. On the left, a velocity map, on the right, a variance map. And since you're beginning to detect the side-to-side turbulence also, that it begins to appear a little bigger and a little broader than the one seen on the left side. So a lot of the appreciation of the jet size and its characteristics really depends on how the instruments are set also. Now to cap it all, the one on the left over here is being seen with a Nyquist limit of 0.6 meters per second. This is with the reduction of Nyquist limit to about 0.15 meters per second. You can see you're seeing a lot of turbulence, and on the one on the right shows a high excessive color flow Doppler gain, which is leading to a bleed over of the speckling signal onto the grayscale image in the right side. So there's a difference between lower Nyquist limit and higher color gain. So besides this jet area, the directionality of the jet is very important also, which shows demonstrates either it's a unilateral disease, valve leaflet disease, or a bileaflet disease, which is a more ominous sign. For example, the one on the right side demonstrates a central regurgitation jet, which implies a bileaflet disease. So that's important because that just gives you a clue of what to look for when you're looking for structural abnormalities in the valve. And eccentric regurgitation jets, which are going one side or the other, appear significantly smaller than the actual size, and there's a specific physical reason for that, and we'll get to that in a second. And usually, eccentric regurgitation jets are due to unilateral valvular structural abnormalities, either retraction of flail, which means flail will go away from the, or prolapse would go away from the affected leaflet and a restriction towards it. And this is referred to as Coanda effect, which means eccentric jet hugs the LA wall, it loses momentum, and at the same time there's lack of entrainment on all sides. The jet kind of flattens out and therefore appears smaller than it actually is. And this can be attributed to this gentleman, Andrei Coanda, a Romanian aeronautical engineer, who used this tendency of the fluids to hug the walls when they move between chambers at high speeds and tend to be curved towards the surfaces. So they use the same principle for designing the wings of the planes. When the air coming from in front of the plane at a very high chamber, because the design of the wing hugs the undersurface of the wing, giving buoyancy to the airplane during flight. So whereas this was a similarity of behavior, not necessarily the same exact phenomenon. As you can see in this eccentric mitral regurgitation jet, the Coanda effect demonstrating an anterior leaflet flail, then we have a posteriorly directed jet. In the next slide, you can see this is a posterior leaflet flail, and we have an anteriorly directed jet going towards the anterior leaflet. And here you can appreciate the Coanda effect and lack of appreciation of the true nature of the jet on the left, which shows a very small, not very small, but thin jet. But when you look at it in 3 dimensions and truly spatially appreciate its width, you can see that it's a broad jet coming out of the entire mitral valve and hugging the left atrial wall and appearing very small in a cross-sectional anatomy of this jet. So at the end of the day, for color flow Doppler, it is important to remember that these maps are not velocity maps, these are volume maps. And driving pressure, that is of the originating chamber and the recipient chamber, the driving pressure can drive the momentum and the jet area for the same volume. And therefore, a larger regurgent orifice area may result in a larger volume and low velocity laminar jet. So a larger jet may actually look smaller, and which is of lower velocity, and a smaller jet may look bigger because of its higher velocity. So this caveat has to be appreciated. Now comes the second most important thing in color flow Doppler, and that's the vena contracta. That's the narrowest portion of the jet, which is high velocity and laminar flow, and slightly distal to the actual anatomical orifice, and is referred to as the effective regurgent orifice area, because the principles of fluid dynamics and hydraulic phenomena have demonstrated that the hydraulic vena contracta is independent of the flow rate and driving pressure for a fixed orifice. And that's because possibly at this location there hasn't been enough time to entrain the fluid or cause that much disturbance. So the narrowest portion of the jet immediately distal to the anatomical orifice area kind of represents the actual anatomical orifice area as well. However, there are certain caveats. The one being the vena contracta by Doppler is considerably less dependent on technical factors. That's the good news with the jet area extent. However, in physiological, actual anatomical principles, it has been demonstrated that the vena contracta by color flow Doppler significantly overestimates the hydraulic vena contracta, possibly because of some color bleed phenomena over the grayscale image. And also that because of the small values of the width of the vena contracta, small errors in its measurement may lead to large errors in its, and misclassification. But lastly, at the end of the day, it's a pretty, simple, straightforward, quickly performed, semi-quantitative measure that seems to corroborate other means of assessment of mitral regurgitation as well. So, when you're measuring the vena contracta to be measured reliably, the 3 important things of vena contracta have to be shown. That is the flow convergence, flow contraction, and jet expansion, so that you can completely appreciate the jets in its entirety and not just looking at a different portion of the jet in a different cut. So all these 3 things have to be seen at the same time to appreciate the vena contracta. When doing transesophageal echocardiography, this is usually achieved in the mid-esophageal long axis view to be able to orient the ultrasonic beam as perpendicular to the flow as possible to take advantage of the axial measurement accuracy. And again, it is performed at the mid-esophageal long axis view and more than likely at the A2P2 section of the mitral valve. Now, 3-dimensional echocardiography has shown particular value in measuring the vena contracta, because if we are lucky enough to get a high frame rate and high spatial resolution image, we can use the multiplanar frames to get to exactly the point of the narrowest orifice in the cardiac cycle and measure the vena contracta at that point. As you can see in this example, we are using a multiplanar frames in real time to look at the regurgitation jet, and in this case, as we will move the blue frame over here and bring it to the point of the vena contracta to know exactly how wide this vena contracta is and where it is exactly located. And as I discussed in my previous slide, this is not at the A2, P2, but actually at A3 and P3, and therefore we could have essentially missed or misclassified the severity of mitral regurgitation if we had depended only on two-dimensional vena contracta. So this method not only allows us to identify the phase of systole when the vena contracta is at its maximal, but its location in the zone of coaptation as well. So at bottom line, we have to use the zoom view, we have to adjust the Nyquist limit and sometimes the baseline to accurately identify the vena contracta, that is the narrowest portion that is slightly distal to the actual anatomical orifice area. Use the zoom view, and when doing transesophageal echo, that be done in the mid-esophageal long axis view. So the next is a flow convergence, which means all the flow from the originating chamber converging towards the effective or regurgent orifice area. And a well-defined flow convergence, as you can see in this particular example, is proximal to the orifice, is very qualitative information regarding not only the severity but also the location, because if large flow convergence at a reasonable Nyquist limit of 0.5 to 0.7 meters per second can be visualized, this is a very specific sign for severe regurgitation, which means normally you have to lower the Nyquist limit, do baseline shifts to see how big the flow convergence is. But if the flow convergence is big enough, even at the regular Nyquist limit, that implies that it is a significant mitral regurgitation. Proximal flow convergence can also be used to quantitatively evaluate the severity of regurgitation, but we will get to that when we use the proximal isovelocity surface area method to appreciate the severity of mitral regurgitation and actually calculate the effective regurgitant orifice area. Now comes the use of pulse wave Doppler, that is for forward flow and flow reversal. Now this is an important concept to remember, because let's talk for the specific mitral regurgitation, because a significant mitral regurgitation imparts volume overload. And if we were to do pulse wave Doppler or the mitral inflow, looking at the E and A waves during diastole, a typical severe mitral regurgitation has a pattern that resembles restrictive pattern, because there's excessive fluid going on during the rapid filling phase. So therefore, there is a significant amount of flow that happens during E waves during the rapid relaxation phase, and the pattern typically remembers restrictive pattern. There's increased E velocity and higher EA ratio. This is a supportive and a non-specific sign, but there's one important caveat to remember, and that is that an A dominant or an impaired relaxation pattern pretty much exclude severe MR in this one, and therefore this is just a manifestation of an increased forward stroke volume. At the same time, severe mitral regurgitation also leads to or bleeds over back into the pulmonary vein. So the systolic phase of the pulmonary venous inflow, which is usually a very positive cycle over here, tends to become negative in a flow reversal. This is also a very specific sign of severe regurgitation. When present, 85% of the time you have severe regurgitation. But again, the absence does not qualify that the patient does not have severe regurgitation. So for the transmitral E and A wave, it is a supportive sign, but it is marred by multiple factors affecting ventricular filling, including diastolic function, ventricular flow obstruction, or alterations in cardiac output. Same goes for the pulmonary venous inflow. It is sort of an insensitive sign, and we should take care to exclude other causes of flow reversal in pulmonary veins, such as atrioventricular dissociation or pacemakers with ventriculoatrial conduction, problem with when the conduction is going retrogradely. Next comes the continuous wave Doppler, and it's three things are important in continuous wave Doppler. Number one, the spectral density, the timing of regurgitation, and lastly, the time course of regurgitation velocity. So continuous wave Doppler is, in the case of mitral regurgitation, we have to look at is the velocity, the gradient, the time course, and timing of regurgitation. But step one should be looking at the spectral density. As you can see, spectral density, while is affected by the continuous wave Doppler gain, really represents the number of RBCs that is going through the mitral valve at that time. As you can see, the intensity or the spectral density implies how severe the mitral regurgitation is and how much volume is going through the mitral valve at that specific moment in time. Like in this sense, there is not too much. It's only in the early parts of systole. This is a little bit more than what is being seen in the first one, and this is a bimodal distribution when we have an early regurgitation and a slightly late regurgitation. So it really gives you not only just the spectral density, but also the time course and when does the mitral regurgitation happen maximally. In this one, it is important to appreciate the V wave cutoff sign of severe mitral regurgitation when, because of the excessive volume that comes from the left ventricle into the left atrium, there's an early peaking and rapid decay of this continuous wave Doppler flow profile because of a rapid pressure equilibration between left atrium and left ventricle, and is very characteristic sign of severe mitral regurgitation. Now let me demonstrate that by an actual case, and I had the presence of mind to do all this at the same time because I had this presentation in the back of my mind. This is a patient that presents for mitral for CABG and MV repair, and as you can see with the changing the severity of MR in the same patient, how does the continuous wave Doppler profile change over time? When this is trace MR, when it becomes too mild, when it becomes too moderate, becomes severe, and eventually we begin to demonstrate the V wave cutoff sign in this situation. Also, this is the actual normal pulmonary venous inflow in this patient, and when we had severe mitral regurgitation, we tended to have the flow reversal with pulse wave Doppler also. So now we come down to the last part of the general principles, and that is quantitative pulse wave Doppler methods and quantitative volumetric method, and finally the flow convergence method. Now, the quantitative approach is based on getting either the effective regurgitant orifice area method, regurgitant volume per beat, and regurgitant fraction per beat. The prior studies have suggested that absolute measurements of effective regurgitant orifice area and regurgitant volume provide the strongest predictors of outcome. However, as I said in the beginning of this presentation, that it is not known whether normalization of these measures to body size, body surface area, body mass index is superior to its absolute values, particularly in women when they have smaller body surface area. And overall, when also when the regurgitation is biphasic, in such partial regurgitation, the regurgitant volume is a better measure of regurgitant severity. This is having said that. Well, I'm not going to spend too much time because these are things that people follow with transthoracic echo in cardiology clinics and outpatients, when you can serially follow the patient, but not so much applicable in the operating room. And that is, but however, it is done for the sake of completion. We take the mitral annular diameter mid diastole, the pulse wave Doppler or the mitral inflow, use the cross-sectional area times VTI, that's the measure of measuring the stroke volume or the stroke distance, to determine the stroke volume of the mitral valve. Then we do the LVOT diameter, the pulse wave Doppler or the LVOT to determine a velocity time integral of the LVOT, and then we measure the stroke volume of the aortic valve. So we have stroke volume at two contiguous locations, and the regurgitant volume is stroke volume, regurgitant valve minus the stroke volume, and regurgitant fraction is regurgitant volume divided by the stroke volume times 100. So that's purely to assess either an absolute difference between the stroke volume of the two valves or the fraction of difference between two valves. And effective regurgitant orifice area can be again calculated from the regurgitant volume that we have divided by the VTI through the regurgitant valve will give you the regurgitant effective regurgitant orifice area. Well, as complete as it is, this is an extrapolation of the continuity equation, and as you can see, the errors that are built into this equation tend to magnify as we make further and further calculations, and the failure to measure the valve annulus accurately, trace the modal velocity of the mitral or the regurgitation jet, and the failure to position the sample volume correctly with this minimal angulation can sometimes cause significant errors. So those intrinsic errors, when all combined together, create a bigger error. And while theoretically this makes perfect sense, but it is not so easy to achieve that in practical sense, particularly so in the operating room. So one of the most important things in the operating room is the PISA method, or the proximal isovelocity surface area method, to calculate the effective regurgitant orifice area. That again is a continuation of the continuity equation, but rather than using velocity time integrals, we are using the peak velocities of certain times. So effective regurgitant orifice area calculation is done by demonstrating flow convergence on the left ventricular side of the valve during systole to identify a point of flow convergence, and that diameter is measured of the flow convergence that we'll see, and how this equation is built into it. So what we need is first demonstrate flow convergence, know the diameter of the valve of this flow convergence, the effective aliasing velocity at which this diameter was achieved, and at the same time the peak velocity of the regurgitant jet. If you go back into it, what this looks like in reality, effective regurgitant orifice area is 2 pi r squared times the velocity aliasing, then goes the peak velocity of the MR jet, that's in the denominator. So this is where we measure the 2 pi r square of the regurgitant jet. This is the aliasing velocity, and this is the peak velocity of the MR jet to give you an effective regurgitant orifice area. And as much as it seems like a complicated equation, this is fast becoming my favorite method of doing it, because the ease of calculating it, or the inbuilt calculations of the system, make it actually very easy to now calculate effective regurgitant orifice area in these patients. So at the bottom line, the timing of measurements is important, because the effective regurgitant orifice area calculated by this approach may not be equivalent to the average regurgitant orifice area throughout the regurgitant phase, which means we're taking a snapshot of a continuous process, and if we get it at the most maximum time, it may not be representative of smaller regurgitant orifice areas over the cardiac cycle, so it could over or underestimate. First, therefore, the measurement of flow and velocity should be performed at simultaneous moments of the regurgitant orifice phase. So it has to be performed accurately and very well to get the real information. And secondly, the PISA measurement most representative of the mean effective regurgitant orifice is that performed simultaneously with the peak velocity of the regurgitation. So you need to have the jet, the isovelocity surface, and the peak jet almost being performed at the same time to get the average velocity. However, this is a snapshot of a continuous process. It may underestimate the bimodal secondary MR, and may overestimate in late systolic primary MR when you just take the most important and the most highest velocity that happens only in one part of the systole and extrapolate that to the entire systolic phase. So it has its certain problems also. Also, the adjustment of the Nyquist limit can make the size of the flow convergence smaller or bigger, and its direction can change also. So therefore, as you can see, the same flow convergence being seen at a Nyquist limit of 1 meters per second, it becomes bigger when we have a Nyquist limit of 0.3 meters per second. And finally, at a Nyquist limit of 0.3 meters per second plus baseline shift in the direction of towards the direction of flow makes the convergence a little bigger, therefore reducing the possibility and the extent of error that would be introduced when doing the linear measures. So flow convergence shape, angulation, and location are also important in looking at it, because it may be eccentric, and it may make it difficult to measure it, and it may also be very small, therefore making a small linear calculation errors can translate into a larger area in the calculation of effective regurgitant orifice area, because it's halved from the diameter and then squared after that, so it eventually becomes quadruple. So a small measurement error in the radius can generate a larger error in the effective regurgitant orifice area. So the bottom line, the effective regurgitant orifice area is equal to 2 pi r square times the velocity aliasing times the peak velocity of the MR jet. Divided by the peak velocity of the MR jet. Let's give you a clinic example of what are the variations in severity assessment that can happen with the different modalities, and how we make a global decision putting integrative information specifically for that patient. So this is a 71-year-old male undergoing elective CABG surgery. They were supposed to have 3-vessel coronary artery disease and unstable angina. They became hemodynamically unstable with elevated PA pressures. This doesn't happen to all our patients. I'm just picking up the ones who have had these problems in the operating room, so just for the sake of this presentation. So baseline mitral regurgitation, as you can see, shows about mild mitral regurgitation, but then as they become hemodynamically unstable, the mitral regurgitation severity increases to be assumed to be moderate intensity. It looks pretty big, and it's certainly not trace and mild, but it is of moderate intensity, and comparing the jet area to the size of the atrium, it looks moderate intensity. However, when we try to do it with the Vena Contracta method, which is simple, quick, and reproducible, by using the zoom mode, by changing the Nyquist limit and the baseline shift, we calculated the Vena Contracta to be about 0.7 centimeter per second. That meant it was severe mitral regurgitation. However, when we used 3-dimensional Vena Contracta to actually align it perfectly with the most narrowest portion of the regurgitation jet in 3 dimensions. It turned out to be 0.4. And when we measured the effective regurgitant orifice area by the PISA method, it turned out to be 0.3 centimeters per square, which involved, as opposed to severe by one method, 2 methods which were quantitative and 1 qualitative method, that was the jet area, agreed with each other in classifying this mitral regurgitation as moderate, and therefore we ignored this vena contracta that was possibly an erroneous measurement based on our misidentification of the vena contracta or the systolic phase, and we ignored this thing and classified this mitral regurgitation as moderate. So bottom line, we'll go over the most important parameters for mitral regurgitation assessment. Number 1 being color flow Doppler, in which you use a velocity map to identify the jet area. You need to see the jet convergence, contraction, and expansion to truly estimate the jet area. This is the most commonly used method. However, it has certain limitations because there are machine settings and geometry of the effective regurgitant orifice area and the velocity of the jet that can make it actually look bigger than it actually is. And we should have a decent Nyquist limit and gain appropriately adjusted with the right frequency to truly appreciate this regurgitation jet. We have the Vena Contracta, which is a simple, straightforward, quick, and reproducible method in which we measure the narrowest diameter of the jet, which is slightly distal to the valve, and this is measured as Vena Contracta, supposed to be representative of the anatomical orifice area and less dependent on machine settings and entrainment, but is a good, supportive, semi-quantitative method of assessment of mitral regurgitation. Then comes the proximal isovelocity surface area method, which is fast becoming very popular and based on extrapolation or continuity equation to determine the effective regurgitant orifice area using the diameter of the flow convergence, the aliasing velocity, divided by the peak velocity of the MR jet going through the left atrium. At the end of the day, the effective regurgitant orifice area measured with the PISA method is a snapshot of a continuous process, may underestimate in bimodal MR, and may overestimate in late systolic primary MR. Having said this thing, I hope you enjoyed this presentation, and remember these practical points that relate to the general principles of assessment of regurgitation across any valve in the heart, whereas I spent more time on mitral valve, but they are applicable to all valves of the of cardiac valves. I hope you liked it, you enjoyed it, and now please stay tuned for the second part in which we'll apply these principles more specifically for assessment of the severity of mitral regurgitation. Thank you and good luck.